This program is brought to you by Emory University.
Okay, good morning, all of you out there in internet land and social isolation land. If your stream is working, you'll see that our speaker today is Dr. Pradhum Ram, one of our first-year clinical fellows. He's going to talk to us about cardio-oncology. Dr. Ram's from India, did his medical training, his medical school in India, came to the United States, did his residency at Albert Einstein in Philadelphia, and he was a chief resident there last year. And as I mentioned, he's a first-year clinical fellow. If you saw the email yesterday, the questions, the way we're going to work the questions today and probably moving forward is you can just text me any questions you have for the speaker. If it seems urgent, I might raise my hand and interrupt him during the talk. Otherwise, I'll probably hold the questions until the end of the talk. If you're having trouble with your stream, you can either text me or Chris Como, and we can see what we can do to help you. And thank you, everyone, for understanding during this unique time. And without any further ado, Dr. Ram.
Thank you, Dr. Williams, for that kind introduction. So, as Dr. Williams was saying, it's I guess it's kind of weird, like speaking to an almost empty room, but most of my practice was to an empty room, so let's see how this goes. My topic for today is basically a brief introduction and an overview to cardio-oncology. This topic is sort of special to me for a couple of reasons. One is that picture was at graduation. My brother was working and couldn't make it, but the others are my parents and my wife. So my mom is a cancer survivor, and ever since she was treated, I started to notice side effects, and ever since I've always been interested in what the side effects of cancer therapy, specifically to the heart, are, and I wanted to read into it more and talk about it today. For disclosure, so I have none. I'm a first-year fellow who's not moonlighting, so open. And fair warning, in my talk, there are going to be points where I say larger studies are needed to confirm these preliminary findings. Bear with me. That's pretty much most of my studies. So for an outline today, what I'm going to be talking about is essentially a historical perspective and a basis for how cardio-oncology sort of came about as a specialty, or a niche-driven focus, key drugs and how they interact with the heart, and their mechanisms of toxicity. Echo with a sort of like an added focus about strain, specifically evaluating these patients who are undergoing chemotherapy. And lastly, also how we detect this toxicity, sort of early, and steps that we can take to prevent it. So from a historical standpoint, this is kind of how it started. There was this patient, he had cancer and he had heart failure. You can guess who's the oncologist there and who's the cardiologist there, but basically a lot of pointing fingers. No, I'm just joking. Basically, the idea came about we had started to notice that, cancer patients are surviving longer, but, they start to have more side effects. And the best way to treat or manage these patients is sort of with shared decision-making, as we're doing in a lot of medicine today, which involves multiple specialties, and try to move the field forward and help optimize outcomes for these patients. That's how this sort of specialty was born. Some statistics, this is from the NCI's data from 2016. Basically, what I've highlighted there and what's important to know is that if you look from the 70s to probably the 2000s, the 70s being highlighted in that box over there, and regardless of race, we see that survival is going up. Just for an example, even in sort of significant malignancies, common malignancies, breast, from 75% to a 90% survival more recently, with colon 50 to 60, 65. So it's just something to keep in mind, that as our treatments get better, our ICU care gets better, survival increases. And there are millions of cancer survivors today in the US, and with the passage of time, as is shown in that next slide, it's the bottom half of the slide, in 2026, the survivors are only thought to increase. And this basically means we're going to be seeing more and more of these patients, and it's important, as even a general cardiologist, depending on where we practice, to have an idea of what some of these medicines are and how they can affect the heart. Chemotherapy sort of started to gather more prominence from maybe the 70s with the introduction of anthracyclines. Since then, there have been some pivotal timeframes with introduction of drugs. Trastuzumab was one of the first sort of antibody mediated medicines came up in the 90s, garnered more importance in the early 2000s, as did a lot of other VEGF therapies. More recently, in the last like 10, 15 years, proteasome inhibitors and immune checkpoint inhibitors have really come into the forefront in improved survival in a different kind of way. But with that, they bring sort of like a different type of side effects, which are important to know as well. This was one of the earlier studies that, kind of got our attention because, anthracyclines were gaining popularity in the 70s, 80s, 90s, like treatment with these patients such as doxorubicin. And we started to notice that patients develop heart failure while they're on this. While an exact mechanism wasn't proposed at the time, this study by Felker, about 20 years old at this point, was published in the New England Journal, where about over 1,000 patients were analyzed with a biopsy. The reference was taken as idiopathic cardiomyopathy, and the others were biopsy-proven diagnosis of like HIV cardiomyopathy, doxorubicin cardiomyopathy, and even infiltrative diseases. What we noticed was that once patients developed chemotherapy-related cardiomyopathy, the 5-year survival wasn't great. 50% of these patients ended up dying, and also heart failure from these patients, especially in older ages, over 65, independently carried like a 3 to 4-fold increase in mortality. This is a busy slide, because I want to go over a lot of pathophys, which is fun for a lot of these medicines. Bear with me, and I'll be delving more in depth as we move forward through the PowerPoint. But essentially, what I'm trying to show on this slide is that multiple medicines, chemotherapeutic agents, all in one way or the other inhibit transcription, damage DNA, or mitochondria at different levels by mediating, through different factors, be it proteasomes, be it DNA topoisomerases, or just inhibiting angiogenesis. All of this sort of affects DNA synthesis, protein synthesis, and causes cell death one way or the other. This leads to, with cells dying, this leads to vicious cycle with heart failure, left ventricular dysfunction, also causes hypertension, and I'll get into that later, and atherosclerosis. A key focus on later on, I'm going to be sort of honing in on HER2 targeted therapies and anthracyclines, but this is just a sort of an overview where you see the different mechanisms of toxicity. So this is just classifying to kind of familiarize ourselves with names, because a lot of the times we see names and just to kind of tell you what class they are. So anthracyclines, doxorubicin, epirubicin, alkylating agents such as cyclophosphamide. More recently, the monoclonal antibodies, trastuzumab, bevacizumab, pertuzumab. The tyrosine kinase inhibitors also come under the subset of VEGF inhibitors, but not directly acting. It's mediated through tyrosine kinase, which are sunitinib, sorafenib, and so on. Proteasome inhibitors are the OMIBs, and checkpoint inhibitors are more of the UMABs, nivolumab, ipilimumab, and so on. So touching on cardiovascular toxicity of chemotherapeutic agents, most of my talk here is going to be sort of centered around cardiomyopathy, heart failure with a focus on echo, but it's also important to realize that there are other manifestations of these medicines. You can get coronary artery disease, arrhythmias, hypertension, and myocarditis is being increasingly recognized from the immune checkpoint inhibitors. Basically, because with the checkpoint inhibitors, the body loses an awareness of self-checking, meaning autoimmunity becomes a huge factor, and autoimmune-related myocarditis is a huge factor. Arrhythmias are thought to arise from the fact that with cell death and eventually scar formation in different regions, including the heart, with arrhythmia as the trigger and substrate, the substrate is there now, so with different triggers, they're more prone to arrhythmias. They can also prolong QT depending on the medicines. We'll walk the rest of this talk being Mrs. K, who's a case that I've started with, who's a 59-year-old diabetic, hypertensive, former smoker, recently diagnosed with breast cancer. Her pathology showed that it was ER negative, but HER2 positive, and it was a ductal carcinoma of the breast. Her oncologist wants to start neoadjuvant chemo prior to surgery and chemo later on. She, being the avid internet buff, as many of our patients are, has looked us up on the internet and comes to you asking that she's read about toxicity and how it's going to affect her heart, and is just generally worried as any normal patient would be. So these are some of the things that we want to discuss with Mrs. K, like, how common is chemotherapy-related cardiotoxicity? What medications in her case, like, would cause her to be prone for cardiotoxicity, and why she is at higher risk, and who in the general population are at higher risk. That brings us to heart failure and cardiomyopathy. This classification here, I've just put it out there more for a historical basis with the type 1 and type 2, where type 1 was thought to be anthracycline, sort of like irreversible. Type 2 was more reversible with like the VEGF inhibitors. But with time and increasing studies, significant overlap is thought to happen between these two classes. And thus, it's sort of like gone away for the most part, but it's just something to remember that, it's kind of an easy way to remember. One is reversible, although there is significant overlap. Anthracycline-related toxicity. Anthracyclines, just so it's out there, will be doxorubicin, epirubicin, and so on, have an acute, early, and a late component to it. An acute, depending on the infusion and the time of infusion and the dose being given, can manifest with LV dysfunction and arrhythmias. Early, usually seen within the first year, and late, several years. The median from a few studies of late toxicity is shown to be around 7 years, but I've read multiple case reports that have shown where based solely on a diagnosis of exclusion, often not with a biopsy, but cases as far out as 20, 21 years and so on after chemotherapy. One thing to remember is people who are at higher risk for this are older age individuals, which is classified as 65 based off the studies. Granted, 80 is the new 60, so probably would change with time. Renal failure, cumulative doses over like 300, and depending on the anthracycline used, all make someone at higher risk. Also, the duration of the infusion therapy, longer durations are thought to be safer, sometimes over 6 hours the infusions last. Now, delving into the depth of how anthracyclines cause damage to the heart. So there's two things that I kind of want to convey with this. One is it damages the heart through reactive free radicals or reactive oxygen species. The second thing is through its effect on DNA topoisomerase beta 2. Now, individually, how does it affect or cause free radical generation? So anthracyclines have a quinone moiety. And so this quinone moiety, when it interacts with molecular oxygen, is responsible for development of free radicals. Also, the iron complex that's present often in mitochondria, which reacts with oxygen to develop these free radicals, and it's sort of with a mechanism kind of self-propagates itself, where certain metabolites kind of reduce it back to its native form, and is ready for oxidation again. Ergo, a lot of free radical generation, and not so much antioxidants to neutralize these. Thus, a lot of free radicals are generated, which causes damage to the DNA and cell death, which is thought to be responsible for the irreversible nature of this toxicity. It's also important to remember that recently in the last maybe 7, 8 years to 10 years, this class of DNA topoisomerases 2 beta, which are these enzymes responsible for stability of the DNA and prevent supercoiling. These anthracyclines damage this DNA topoisomerase 2 beta, which results in increased cell death as well. This would be an important point to remember, especially with dexrazoxane, which is one of the preventative mechanisms, which I'll delve into later, but it's just something to remember. Now, as I was mentioning, dose dependency is also an important feature here, where you can see the incidence of toxicity with doses under 400. These are cumulative doses, meaning including all of the cycles. An average dose per cycle is probably 60 milligram per meter square, with 3 to 4 cycles, depending on the cancer and how resistant it is. As we go higher, that toxicity increases, but you can see that the doses, depending on the medicine here, with epirubicin being over 900, with slightly lower toxicity. So it varies based on the medicine and the amount that the patient receives. What's also very important and interesting to remember is in more recent times, certain genetic factors, and specifically one of these known as CBR3, which are the carbonyl reductases. So carbonyl reductases are sort of like this group of enzymes that are responsible for stability of the topoisomerases. So in patients who inhibiting topoisomerases, so in patients who are homozygous for the allele, even very small doses of anthracyclines could be responsible for significant toxicity as compared to patients who are heterozygous for the same alleles. That's something to keep in mind. Also, Patients with retinoic acid receptors are also prone to be more susceptible to toxicity, and studies have shown these, mostly in mice, but chances are in humans as well. This is kind of delving into that same fact that a lot of the time when we see toxicity, it's clinical heart failure. But it's important to realize that a lot of these patients develop subclinical LV dysfunction, which is sort of really where strain has caught on and kind of like playing an important factor. This was one study from JACC CV imaging from a few years ago, which evaluated men and women with breast cancer treated with anywhere from 50 to 300 milligram per meter square of anthracyclines. They were evaluated by CMRs and echoes with strain as well. What we saw that even though none of these patients had overt heart failure, but what we see is their end systolic volume over time, over 6 months, increases over there. And at the same time, their EF drops. EF is on panel B in the green line, and the strain is what's getting, from negative 20, which is to about negative 14, which is also a drop there. And I'll get into that later. And the end systolic volume is on the upper graph, which we can see that it's increasing to about 55. This suggests that, even though patients may not manifest overt signs and symptoms of heart failure, they are susceptible to toxicity. Another class of agents that are very important are the HER2/neu agents. So HER2/neu basically is a receptor that's under the subfamily of epidermal growth factor receptors. It's expressed in cardiac myocytes. Now, through the mechanism for the toxicity is basically, again, it inhibits DNA synthesis, but how? What happens is essentially the HER2 binds with the epidermal growth factor receptors, which causes downstream signaling responsible for two things, which A, inhibit DNA synthesis, and B, this complex is thought to be very important in myocardial, the complex of ERBB2 or HER2. ERBB2 is just erythroblastic viral oncogene receptor B2. They're thought to be kind of like sister receptors. The complex that it forms with the growth factor receptor is very important for myocardial stability. Now, with this being inhibited, two things happen. One is the cell is more prone to death and more prone to other stressors, which includes anthracycline use. The graph up top over there just shows incidence of heart failure with patients who are receiving these therapies. With the metastatic trial highlighted up there, up top, where they were given concomitantly together, which shows the highest incidence of heart failure, compared to some of the others, like the National Surgical Adjuvant Breast Cancer Therapy, the Breast Cancer International Research Group, BCIRG, and the North Central Cancer Therapeutic Group, which was NCCTG, and the Herceptin adjuvant, just basically tells you that they started Herceptin or so many days after giving the anthracycline. And you can see that the incidence is much lower, which sort of plays into the fact that that the complex formed by trastuzumab with the epidermal growth factor receptor is very important for myocardial stability. So with that inhibited, it makes the cell more susceptible to other toxins. VEGF toxicity is, so HER2 is a epidermal growth factor receptor, moving on to endothelial growth factor vascular receptors, which would be basically in two flavors. One are direct inhibitors, which would be bevacizumab, and the others, which by inhibiting tyrosine kinases cause inhibition of angiogenesis using sort of the same molecular pathways. I wanted to focus on the tyrosine kinase inhibitors here to sort of explain why they cause hypertension. Up to 50% of patients taking these medicines are thought to develop hypertension. Now, downstream signaling of the VEGF pathway is you develop nitric oxide and prostaglandins. With that being inhibited, you have a reduced amount of vasodilators, ergo causing vasoconstriction, which leads to hypertension. And toxicity or incidence of heart failure, I've listed with multiple medicines. Commonly seen, these days, sorafenib, sunitinib are used predominantly in renal and hepatocellular cancers, which have an incidence, depending on the study that you use, from anywhere between 1 to 10%. How do we risk stratify these patients? So Mrs. K comes to you, and I want to know how much a risk she is, right? So she's a hypertensive and a diabetic. This is something to keep in mind, where we don't lose track of our function as general cardiologists, where risk factor modification is key. Exercise therapy has also been shown, as almost with always, that a targeted or structured exercise program improves outcomes in these patients, lowering their A1Cs, controlling their blood pressure with targets of 130s over 80s, at least on the studies listed. were thought to help, improve their overall quality of life and occasionally morbidity as well. Now, I'll be focusing in on EF assessment as well, talking a little bit about where troponins stand, which would make the ER pretty happy in this situation, and focusing on myocardial strain just a tad bit. So I've put this up there, this expert consensus statement. Why I like this is basically it combined the JACE guidelines and the European Society guidelines sort of into one combined article. It's an expert consensus, but this is also sort of a specific topic. Now, I'm kind of going over what we should do when we're thinking of starting someone from a cardiologist perspective, starting someone either on anthracyclines or trastuzumab. Trastuzumab seems to be slightly more straightforward, so I'll deal with that first, in which case, before starting someone on it, you get a baseline echo. It could either be 3D echo, 2D. In these cases, we prefer contrast, or you could get strain and a troponin. A troponin and an echo together is thought to increase, their negativity, if they're both normal, is thought to increase the negative predictive value significantly. Now, if all of that's normal, the LVEF, the cutoff that they have used in this study, in this paper, is a cutoff of 53%. So an EF of more than 53% with a strain greater than the lower limit of normal, which is thought to be, depending on the machine used and the program used, but if they're Philips or GE machines, about negative 17 and a half, it's thought to be that cutoff of normal. And troponins, if all of this are normal, you just keep getting echoes at 3-month intervals, usually coupled with their cycles to see if there are any changes. Now, if all of this is abnormal, the thought process is to get a cardiologist on board, and we'll delve into the specifics as to what we can do about the medicines as well. From an anthracycline standpoint, it's important because here in this case, the risk factors of the patient, age, renal failure, EF at beginning therapy kind of matters, and the dose of anthracyclines that they're receiving as well. You get a baseline echocardiogram, and sort of the same thing depending on whether you have toxicity, features of toxicity or not so much. If everything's progressing normally, the thought process is to get a repeat echo at completion of therapy and 6 months after. However, if the patient is receiving significantly high doses, the cutoff used based off this paper is more than a cumulative dose of 240 milligram per meter square, or its equivalent on others such as epirubicin, which is about 500 to 600, I believe, milligram per meter square. You might consider getting more frequent imaging. Anthracycline cardiotoxicity. Now we've got the echo. What do we do next? So the goal of all of these, of our role in these patients is to try and get them to keep their chemo as long as possible, because that's really what's going to help them in the long run. Granted, heart failure could kill them as well, but it's their cancer that we're really trying to help with. Now, if their EF is more than 50%, to continue chemotherapy, get an echo at completion of therapy. Now, if the EF is less than 45%, this is with anthracycline specifically, we stop chemotherapy, and this is when we start heart failure-related therapies such as ACE inhibitors, ARBs, beta blockers. Occasional studies have also shown aldosterone antagonists to be helpful in this situation. Now, if we're in that gray zone, kind of like limbo, it's important to see what the drop in EF is compared to the baseline. If it was more than 10% and it's about 46, 47, in that case, the thought process is to hold chemo temporarily till we repeat an echo after initiating ACE and ARBs, and the time frame for this, depending on the study, is 1 to 3 months. If the EF decline is less than 10% and the EF is still more than 45, the thought process is to continue with serial echo imaging to make sure it's not getting worse. For Herceptin, it's a little different. The surveillance echo, if it's over 50, same thing. Echo every 3 months, continue chemo, don't worry about it. Well, worry about it and get the echoes. If it's less than 40%, we hold chemo. If it's between 40 and 50, we start treatment with beta blockers, ACE inhibitors, and we look for a change, a delta change in EF. If it's more than 15%, we hold chemo, repeat echo. If it's less than 15%, we still repeat the echo to make sure that the patient's tolerating it, but we try and continue chemo, therefore not interrupting the patient's regimen. Now, biomarkers in this setting are also thought to be important, and here's why or how this came about. This was a study from Daniela Cardinale up in Italy from way back in 2000, which was a single-center study where 204 patients who are undergoing high-dose chemo. What high-dose chemo in this study meant was the patient, regardless of the cancer, had failed first-line therapy and was on second-line therapy with anthracycline doses going over 300 milligram per meter square. Troponin was measured before and after each cycle. Those with the troponins positive is the dark, sort of like the square up top, and those with troponins negative are up top, and those with troponins positive are down below. My apologies. And as you can see, as the time moves on, although both of them do have a drop in EF, notably at 3 months, in those who with the troponin negative, you can see that they tend to recover their EF, whereas those with the troponin positive do not. Experts also tend to recommend measuring strain in these settings as well. This was another study from the same group a little bit later where they looked at just a different way to tackle the same problem. They measured troponins early on and after each cycle and late. They classified as early troponin positive, which is within 72 hours of receiving chemo, and late troponin positive, which is about a month after the last dose of chemo. The dose was significantly high in this, and we should know is that the average anthracycline dose was about 500 milligram per meter square. You can see of the 700 patients, close to 500 were negative, and you can see that they're they're free of an event meaning death from a cardiovascular cause, heart failure, a drop in EF of more than 25%, or a life-threatening arrhythmia was pretty good. Those with an early positive troponin but late negative were somewhere in between, and what's important is to look at the two extremes. Those with positive early and positive late had pretty dismal outcomes as compared to those with negative troponins. This sort of kind of formed the basis for why troponins are integrated as part of this overall process, not solely as a biomarker, which is diagnostic, but just to help with overall prognostication of these patients. And because together with troponins being negative and strain being normal or EF being normal, the negative predictive value for these patients through their cycles of chemo start to exceed 90%. This brings us to an important topic of myocardial strain, which before I get into it, I just want to mention that, the myocardial strain it depends on the software, what we're measuring. Like the key word in that is myocardial. Sometimes just based off of the images that we get, we won't be able to really trace that myocardium, and we might get pericardial or endocardial, strain, which isn't the values that we use. So it just goes to show that the myocardium, the tracing is really important, and strain is affected by several other loading factors. But with these Philips and GE machines that are commonly used, a cutoff of about -17 is used as normal. Anything more negative than that, 17 and a half. What is it? Now, strain is basically a dimensionless index which looks at myocardial deformation. It takes a cardiac myocyte and has its resting length. Let's call that length 0. And during systole or contraction, it starts to thicken, ergo shorten. So that change in length with each beat, when you compare that with the baseline, it starts to give you the strain, which is why it's like a predictor. It runs more negative. So minus -17 and beyond, -20, -21, -25 are all thought to be normal and good. Less than that, anything like -15, -12, -10, depending on the change of strain from the baseline, is something to keep in mind and important. Why this sort of became exceedingly important was because are looking at the sort of observer variability with just 2D echocardiogram assessing the EF. It's sort of like a ballpark. I'm estimating it, and I have some experts in the room here, so my estimate of something could be very different from, let's say, Dr. Clemens's, which is which comes from years of experience, whereas strain tries to eliminate that, and depending on the tracing has some more objectivity to it, and which is very important. Also, strain was shown, regardless of the strain, longitudinal strain, radial strain, circumferential strain, which I've shown here, just basically depending on the direction of deformation of the myocyte is important, and all of them have been shown to, depending on the study, to precede LV dysfunction on a 2D echo and be indicative of subclinical dysfunction as well. Now, for the same thing, this is just an example of why I'm trying to say that this is so important. Based off of the guidelines, initially, this is a patient naive, a baseline echo with an EF of 61 and a strain of -20. We look good. Now, 6 months in, the EF is 55. By our guidelines, we're still continuing therapy, but this delta strain is something that we need to focus in on. So looking at the delta strain, you can see that it's now 70 compared to 20. So that's about a change of 3. And when we evaluate that change, it's about a 15% change. This cardinal study with this review showed that a delta strain or a change in strain of less than 8% was thought to be okay and not indicative of subclinical myocardial dysfunction, whereas over 15% was thought to be significant, and which is currently as part of the expert statement as well. So coming to the expert statement on strain, essentially, as I was saying, a drop in EF of more than 10 points or less than 53, we have no doubts about, that's chemotherapy-related cardiac dysfunction. But let's say it's over that, we look at the strain as a predictive of subclinical dysfunction. If the delta strain is more than 15%, this is still someone I'd want to start on ACE inhibitors or beta blockers. Pause, I'm just going to take a sip of water. Same thing when we add troponins to that mix. A troponin being normal through all the cycles of chemo, as well as your myocardial strain being normal, delta strain being less than 8%, the negative predictive value is over 90%. If both are abnormal, at some point in their chemotherapy, in their course of chemotherapy, most of these patients do develop cardiac dysfunction. Touching upon some other important concepts that I really won't delve into, I briefly touched upon immune checkpoint-related myocarditis, which is basically an autoimmune sort of phenomenon that results in myocarditis. It's really becoming more prominent in these recent years. The incidence thought to be less than 1%. Arrhythmias as well, based off of scar formation, QT, and so on, and radiation therapy. I'm not delving into mostly for time, but it's just something to keep in mind as patients may be, let's say Mrs. K had received radiation therapy to the heart. Radiation therapy on the heart has its own set of problems that it causes or damage to the heart that it can cause, and it's just something to keep in mind with the dose of it and how it can affect the heart. Other imaging modalities, MRI. MRI is often considered the gold standard for a lot of these things, but it's a higher cost and it's a longer test. Whereas in comparison, echo and strain are relatively cheaper. MUGA scans, many of these guidelines, which were done, which have formulated based off of studies from the 70s, 80s, 90s, where this was used a lot. Now, it's either or, it still can be used as a viable alternative, but it's important to keep in mind that with each scan, the patient gets a little bit of radiation. Now for a little bit of a quick break and some trivia. Well, I'll ask the audience in the room here, so these four people, there's something in common to the ones on the top row and the ones on the bottom row. And full disclosure, I tried to find a more normal looking picture of Angelina Jolie. There are none. So for the guys up top, what do Ms. Applegate and Ms. Jolie have in common? Anyone?
Breast cancer.
That's on the right lines. Basically, both of them were BRCA mutation positive. Ms. Applegate had breast cancer and underwent a mastectomy and chemo. Angelina Jolie took it one step further. She had a family history and a BRCA positive gene, so prophylactically she underwent a mastectomy. The guys below as well, De Niro and Navratilova, all suffered from breast cancer and are survivors at this point. All right, moving on. So now what can we do? We know Mrs. K, we know what she's going to get, we know what her risk factors are and what we're going to do. How can we help prevent her from developing cardiac toxicity? So we can identify risk factors, her hypertension, her diabetes, make sure they're treated well, they're at goal. We can ask her oncologist, hey, are there any other options that we can do? We can try and not combine HER2 new therapy with an anthracycline together or space these intervals apart. Other formulations such as liposomal doxorubicin. We can try and prolong her infusions, not greater than 6 hours. And we can also try and treat the hypertension, make sure it's at goal. All of these things, while not the sole therapy, all of them play a small part in making the overall outcome better. Dexrazoxane. Now this is in patients with anthracycline-specific chemo-related toxicity has proven to be protective. It's in the guidelines and it can be used in patients receiving greater than 300 milligram per meter square of anthracyclines. Why this dose is rather high to use this medicine is for two reasons. One is there's some small studies out there that shows that it can perhaps inhibit the efficacy of these agents. The second thing is that sometimes it also is thought to induce cancers at other sites. Again, can you attribute a cause-relation sort of effect to this? Not really, but these studies have shown an association, so it's just something to keep in mind. How does it function? Basically, it's an iron chelator, and in the mitochondria, the anthracyclines generate free radicals. by binding to these iron complexes and generating these free radicals. Dextroxane, being an iron chelator, binds to the iron. Ergo, the anthracycline can't bind, and no free radicals are generated, which helps protect them. Which also kind of makes sense as to why maybe the efficacy goes down a tad bit, because that's also the way anthracyclines work. So the ASCO guidelines say that patients using high doses of these agents, you can consider using these agents. Other more standard preventative therapeutic options, ACE inhibitors, ARBs, beta blockers. Historically, multiple small studies had shown an association between these agents. And there were no clear recommendations at the time for starting before, seeing overt evidence of LV dysfunction. So this is one of the studies, again by Daniela Cardinale in 2006, where she followed, it was a single-blinded study of 114 patients with receiving high-dose chemotherapy. 56 of these patients were started on enalapril, received get a total of 20 milligrams a day, and the others were on placebo. The thought process was, after starting chemotherapy, at the 1 month mark was when the medication was started and up-titrated. The endpoint was a decrease in EF of more than 10%. As you can see, the patients who did receive the enalapril, their EF did not drop as significantly as those who did not. And the same thing goes with serial echo imaging at 1, 3, 6, and 12-month follow-up. Talking about moving on with these patients, the troponin values as we were followed, at onset, those who had an elevated troponin, as we move through time, you can see that the open bar is patients who were on ACEs, and the black bar is patients who are not. You can see while they did drop sequentially, the proportion of a drop in patients with receiving ACE inhibitors were far more significant. This study, patients on ACE inhibitors were hardly any events, as opposed to patients on placebo who had a more significant decline in EF.
Quick question about the troponin. I assume these were just random. There's not necessarily any timing to when they.
No, it was coupled with the same thing at 1 month, 2 months, and 3 months. So the M1, M2, M3, M6. It was just study design and.
But not in terms of like infusions or anything.
No,
like that.
not in
Just
terms. It was just
random draws.
random blood checks. Yep. Which leads us to the Overcome trial. This was a randomized trial where patients were compared with enalapril and carvedilol, in patients undergoing intensive chemo, mostly for hematologic malignancies or stem cell transplantation. What we did notice in this, if you look at the enalapril plus carvedilol group, the drop in EF compared to baseline, as evaluated by echo and CMR, was far less as compared to patients on placebo, which sort of started to gather some interest in should we preemptively start these patients on treatment with these agents. Again, most of these studies were small, and as I mentioned, larger studies were needed to further evaluate these findings, which brought us to the Prada trial, which was a 2x2 sort of factorial treatment where patients who were these were patients who were undergoing anthracycline-based chemotherapy for breast cancer, with or without trastuzumab added to them. They were stratified into sort of 4 categories: either candesartan and metoprolol succinate, candesartan and placebo, metoprolol and placebo, or placebo-placebo. The first thing, the main outcome was a change in EF, and greater than 5% in this study was considered significant by CMR. They tried to compare metoprolol and candesartan with about 30 patients in each arm, and noticed that there was no significance when you compare one against the other, whereas candesartan versus placebo and metoprolol versus placebo was a different story. The EF from a candesartan perspective dropped by about 0.8% in patients receiving candesartan, as opposed to about 2.5 to 3% in patients receiving placebo. In metoprolol, this drop was not as significant. There was no difference in strain, and some of the criticisms of this study were, because of the sample size and maybe between about 40 to 50 patients receiving beta blockers, was this adequately powered and adequately sized to actually notice a difference? Which is just something to keep in mind. But in candesartan, there was a difference that achieved statistical significance. Moving forward to the CC trial, this was carvedilol for the prevention of chemotherapy-related toxicity. These were patients, prospective, randomized, double-blind study with HER2 negative breast cancer, A normal EF, the mean dose of anthracycline in this was 240 milligram per meter square. They were, I'll get into how they were started on carvedilol or placebo till the end of chemotherapy. The endpoint was a drop in EF greater than 10% at 6 months. Secondary outcomes were its effect on troponin and diastolic dysfunction. So this study was exciting at the time, and the anthracycline infusions usually happen at 3-week intervals, and apart from that, along with physical exam at these weeks, troponins were also measured serially, and echo was done at 6, 12, and at completion of therapy, which was 24 weeks or 6 months. Biomarkers were collected as well, and what did we find? Unfortunately for the investigators, and which came as a sort of a disappointment to us, it was really no significant difference was seen in patients receiving carvedilol or placebo. This table is just to show that they were pretty evenly matched, not too many significant differences there, including the doses, the comorbids, so on and so forth. The average blood pressure in both the groups were pretty much the same as well. Patients in the carvedilol group with an LVEF greater than 10% drop were about 14, and in the placebo group were 13. And unfortunately, this didn't meet, there was no difference seen between these two groups. What we did notice was that carvedilol was beneficial in sort of like lowering troponin values and in predicting a lower incidence of diastolic dysfunction. But again, take these with a grain of salt in that these are all short-term outcomes, 6-month intervals. And the other thing to keep in mind is that we're not evaluating for overt long-term heart failure, like if it's a year later, if it's a few years out. This was all till just the completion of the study. It's just a graph showing troponin values. Carvedilol is the blue line, which you can see at 12 weeks was lower compared to the placebo. This was a study which came out last year, presented at ACC, I think a year before that, where comparing lisinopril carvedilol to prevent trastuzumab cardiotoxicity in patients with breast cancer. These were about 500 patients. It was randomized, it was a well-done study, double-blind. HER2 patients all receiving trastuzumab. These patients were started to receive lisinopril, carvedilol, or placebo, again at good doses. I believe the lisinopril median dose was close to 20 milligrams and carvedilol was 25 BID, or placebo. What we noticed was in all comers, that's including patients who received anthracyclines, those who did not receive anthracycline, unfortunately there was no difference in primary outcome, which was a drop in EF, more than 10% to less than 50%. What we did notice was then they sub-analyzed these patients to see who received anthracyclines and those that did not. In patients who received anthracyclines, as compared to placebo, where 50% of these patients developed heart failure as defined by the study, only 30% of patients on carvedilol and 37% on lisinopril developed these symptoms and signs of heart failure, which was significant. Again, a more recent sort of like meta-analyses, which combined a lot of this data that has just been included, which essentially stated that when we include all of these trials for ACE, like sort of like neurohormonal therapies against anthracycline-related like toxicity, a drop, like the drop in EF or the protective factor was about a 4% protection against an EF drop. So if it was like 50 to 42 compared to 50 to 46 if we have these medication therapies. Again, despite having 17 studies in this, we should know that there was significant heterogeneity in these studies, and a lot of them had smaller samples and different agents used at different doses. So just something to keep in mind as well. So now Mrs. K comes back to you. She says, hey, I'm doing great. You got that baseline echo on me. I feel good. So she's coming back. She's on 3 months of therapy, and she's with trastuzumab. So hey, at 3-month mark, I'm checking another echo with strain. What do I notice? The EF is still normal in both, 62%, 57%. But I do notice that the strain has dropped from 20.7 to a negative 16. What I'm trying to convey with this slide is that the delta strain here is more than 15. So what would I do for Mrs. K? Which brings me to what are the current recommendations for this patient? I would start treating this patient with ACEs or ARBs, depending on what her blood pressure and heart rate tolerate, and renal function, so the usual things that we look for in these patients. Granted, we have to take that into consideration. I would try to continue chemo as long as possible. Her EF is more than 50. I would continue the regimen with serial echocardiographic imaging. For her, with her imaging, as long as it doesn't drop below 45 on anthracyclines or 40 on HER2s, we're okay continuing the therapy. And The addition of ACEs and beta blockers in her would thought to slow this decline in EF/stabilize it, if that makes sense. This is just a summary of the same recs. How do I prevent toxicity in these patients? Try to dose reduce, continuous infusions, different formulations, less toxic agents. Treat the hypertension, treat risk factors. EF less than 50, dropped in 10%. I try to cardioprotect these patients. For a GLS, the delta strain or a drop more than 15% is thought to be significant. Myocardial damage, we check. We can't underestimate the effect of troponin as an adjuvant to like EF or strain in these patients where with both of them being negative, again, has a negative predictive value of over 90%. When do I hold? Less than 45 with anthracyclines, less than 40 with HER2s. Who's at increased risk? Pretty much is the converse of what we went over. Those receiving high doses of these therapies, those who get trastuzumab plus anthracyclines together, radiation therapy involving the heart, which is its own sort of like demon, and take into account age, comorbids, renal function. All of this can have an additive effect. Preventative strategies, if her dose goes over 300, per the guidelines, we can use dexrazoxane. We can serial imaging, any of these agents available here would be right. 3D echo included in that, which I did not. 2D echo, MRI, biomarker. Biomarker is always used in conjunction with something, not as a standalone, and strain imaging. Now, before I conclude the talk, I just wanted to throw a quick line about something that I was consulted upon when I was in Gen Cards, and I just thought, you know, we probably get called about often, so just reading into it and seeing what the guidelines say about this. And I found that there are no guidelines, but some expert opinions on this topic. So Mr. K is a 60-year-old guy. He had a CAD, drug-eluting stent to the mid-LAD about 2 months ago, after which he was unfortunately recently diagnosed with a lymphoma. He was treated with CHOP about 1 week ago. And today on a routine surveillance blood test, his platelet count is known to be 40, white count of 3, and hemoglobin of 7. Now, he's on DAPT. What would I do on this patient who's on DAPT, whose platelet count is 40,000? Which is pretty much very similar to the consult that I got, except the patient had a platelet count of 30 or 35,000. Now, thrombocytopenia in cancer patients and what we should do with these patients. So one thing to remember is, are they bleeding, are they not bleeding? If they are bleeding, which could be pretty much an overt bleed, hematuria, nasal bleeds, GI bleeds, unless they're bleeding, don't transfuse them. Or if their platelet count is less than 10,000, you can consider transfusing them. If their platelet count is less than 30,000, and this is pre-stent, we should really have a discussion, because it varies depending on expert to expert, as to whether they would feel comfortable stenting this patient and starting him on DAPT. We should also know that with the advancements in just stents, we can get away with as early as sometimes even 4 to 6 weeks after a drug-eluting stent of dual antiplatelet therapies in these patients. We should not use, this is again based off of an expert opinion in 2016 and CCI, which I'll pause at the end of my talk and ask Dr. Douglas, as he's here, what his opinion would be on this issue. But what they stated was, if it's less than 50,000, to avoid ideally using ticagrelor, prasugrel, and 2B3A agents as well. It's just something to keep in mind. Now, if the platelet count is over 10,000, you can consider continuing aspirin, but DAPT, again, becomes a tricky issue, varies from provider to provider. Because these patients are obviously more prone to bleeding, if you can, cat them with a radial approach as opposed to the femoral approach. That brings me pretty much to the end of my talk, and this is just some additional reading that I found quite interesting and fascinating, different guidelines, different position papers on the subject, which helped increase my knowledge on the subject. And with that, I thank you guys and ask for questions.
I'll start with a public service announcement about strain. It's gotten better. As time has gone on, I think our echo machines are better at detecting strain and analyzing the data. But I think as cardiologists, it's important when you get an echo report that talks about the strain numbers, particularly if there's been a change, one thing that's important is to go back and look at the source images. As you probably know, Ram, that the image quality has a big effect on the quality of strain data. So, you know, sort of in the differential diagnosis of a change in a patient's strain might be their chemotherapy, but it might be a poor quality echo. So I would just say that the better the image quality is from the source images, the more reliable that strain number is. So I might go back, you know, particularly if I was thinking about stopping someone's chemotherapy, I might go back and look at the images and be like, you know, I'm not sure how much, you know, if the EF's okay and the patient's otherwise doing well, but the strain is dropped, the image quality is poor, you might be one of those, like, take it with a grain of salt numbers.
Absolutely. Thank you.
That's exactly right. You know, to do that strain, longitudinal strain, you've got to have 3 good apical views. And you got to see all the walls, particularly the lateral wall. If you can't see them good, it'll give you a little X out there. We're talking primarily about the GE machine, not the Philips machine. They give you different values. But we love to see that when we can get good images. And, of course, we have our favorite strain images to look at and things like amyloid and Takotsubo and all that stuff. And regions of infarction. Anyway, that was great. That was a lot of material. And it's just a testament of why cardio-oncology has become a specialty in itself. Thanks.
Thank you so much, Dr. Clement.
Ask John about the platelets.
Yep, I'm waiting.
Well, you know, with the better stents that we have now, the thin struts and so forth, things are much better. So, you know, 4 to 6 months of dual antiplatelet therapy, you know, is something you can frequently, do well with. It may depend a little bit. I mean, your decision may depend on where the stent is. If it's stent's in the left main, you might want to try to extend that dual antiplatelet therapy longer if, you know, and the patient is not bleeding. But it's very difficult.
All right, thank you, guys.
The preceding program is copyrighted by Emory University.